We're just going to start with Quran in about 2 minutes. So if everyone can start finding their seats, we will start.
بر محمد و آل محمد صلوات. اعوذ بالله من الشیطان الرجیم. بسم الله الرحمن الرحیم. قد كان لكم آية في فئتين التقتا فئة تقاتل في سبيل الله وأخرى كافرة يرونهم مثليهم رأي العين والله يؤيد بنصره من يشاء إن في ذلك لعبرة لأولي الأبصار. الله أكبر ولله الحمد. بسم الله الرحمن الرحيم. وقرن في بيوتكن ولا تبرجن تبرج الجاهلية الأولى وأقمنا الصلاة وآتينا الزكاة وأطعنا الله ورسوله إنما يريد الله ليذهب عنكم الرجس أهل البيت ويطهركم تطهيرا. واذكرن ما يتلى في بيوتكن من آيات الله والحكمة إن الله كان لطيفا خبيرا. إن المسلمين والمسلمات والمؤمنين والمؤمنات والقانتين والقانتات والصادقين والصادقات والصابرين والصابرات والخاشعين والخاشعات والمتصدقين والمتصدقات والصائمين والصائمات والحافظين فروجهم والحافظات والذاكرين الله كثيرا والذاكرات أعد الله لهم مغفرة وأجرا عظيما. الله أكبر ولله الحمد. بسم الله الرحمن الرحيم. إنما المؤمنون إخوة فأصلحوا بين أخويكم. إنما المؤمنون إخوة فأصلحوا بين أخويكم واتقوا الله لعلكم ترحمون. يا أيها الذين آمنوا لا يسخر قوم من قوم عسى أن يكونوا خيرا منهم ولا نساء من نساء عسى أن يكن خيرا منهن ولا تلمزوا أنفسكم ولا تنابزوا بالألقاب بئس الاسم الفسوق بعد الإيمان ومن لم يتب فأولئك هم الظالمون. يا أيها الذين آمنوا اجتنبوا كثيرا من الظن إن بعض الظن يا أيها الذين آمنوا اجتنبوا كثيرا من الظن إن بعض الظن بعض الظن إثم ولا تجسسوا ولا يغتب بعضكم بعضا أيحب أحدكم أن يأكل لحم أخيه ميتا فكرهتموه واتقوا الله إن الله تواب رحيم. صدق الله العلی العظیم. سلامتی آقای امام زمان. سلامت.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين أبو القاسم محمد وعلى أهل بيته الطيبين الطاهرين المعصومين. For the return of our Imam, please recite aloud salawat ala Muhammad wa ali Muhammad. Brothers, sisters, respected scholars, elders, community leaders, Assalamu alaikum wa rahmatullahi wa barakatuh. A very warm welcome to each and every one of you to tonight's program. Thank you for joining us here this evening for what is a truly important topic. By way of an introduction, my name is Alexander Khalili, and I have the honor of serving as the head of the International Center for Advanced Islamic Research, which is a department within the World Federation of KSIMC, based in London. On behalf of ICA and on behalf of our partners this evening, the Az-Zahraa Center, who very kindly hosted us here and spared no effort in accommodating our needs, on behalf of Nasimco and on behalf of IMI Canada, thank you for giving us your Friday evening. Tonight's title, the title of tonight's event, Dying an Islamic Death in 2026, names something that I think has touched or will touch every family in this room, and something that none of us really talk about until we're forced to by circumstances that are mostly beyond our control. I want to set the scene by beginning where this subject actually lives, which is not in a mosque, not in a lecture hall on a Friday evening, but somewhere in a hospital corridor in the early hours of the morning. A family is gathered outside an intensive care unit. Their father, their mother, their grandfather, their grandmother, someone has been ill for a very long time. And tonight, the doctors have asked them a question. Do you want us to continue? Do you want us to continue administering the treatment? Do you want us to continue the machine that is breathing for him? Continue the intervention that will not make him better, but will only keep him where he is, which will only, perhaps they will say, prolong his suffering. Now, this family is a family of faith. And in this moment, which is a terrible moment for any family to face, they're actually trying to do two things at once. And in some cases, they feel like they're being pulled in two opposite directions. On the one hand, they are trying to love their father, their grandfather, their mother, their grandmother, whoever it is in that intensive care unit. They're trying to hold on to that love and that feeling of responsibility. But at the same time, they are trying to obey their Lord. Now, in this moment, they're already overwhelmed because they're being confronted by the death of a loved one. So they cannot make this decision alone. Someone will phone an uncle, maybe overseas. Someone searches the internet. Someone calls a sheikh. Maybe two sheikhs. And they receive different answers. And in that corridor, in that early hour of the morning, they carry this fear in their hearts. The fear that perhaps we have all in this room at some point experienced. What if we make the wrong decision? What if, in trying to keep our loved one alive, we end up prolonging their suffering unnecessarily? But what if, in trying to do what's best for our loved one, we disobey our Lord? That corridor, that scene I've just painted for you, is why we're here tonight. Because for nearly all of human history, no one had to grapple with these questions. No one had to ask these questions. Because death was something that simply happened to you. In the vast majority of cases, if you were dying, you were dead. You never had to decide anything. The illness would run its course. You would recover or you would die. Your injury would heal or you would die. You would live or you would die. It was simple. But modern medicine has changed that. And alhamdulillah, ventilators, dialysis, resuscitation, artificial feeding, advanced oxygen support, these technologies save lives every single day. And I'm sure that many of us are alive, or have parents who are alive, or children who are alive because of these technologies. But they have also done something unprecedented in human history, and that is that they have transformed death from something that happens to you into a series of decisions. Decisions about starting treatment, about continuing it, about escalating it, about ending it. Decisions that in the past we would assign to an almost inscrutable divine decree now have been placed into our hands. Do we decide to keep our loved one alive? Do we decide to let them die? These are now in the hands of human doctors and human families. And so questions arise that our grandparents, that our ancestors never had to ask. When is treatment obligatory, and when does it stop being so? Where is the line between allowing a natural death and causing death? How do we weigh suffering, and how do we weigh the patient's own wishes against the moral imperatives of the divine Sharia? And there is a quieter question beneath all of these. Our spiritual tradition, the tradition of the Ahlul Bayt alayhim salam, surrounds the dying person with its own form of care. If you look at the sunan, the practices prescribed by the Prophet and the Imams for how we are to treat the muhtadir, the person who is on their deathbed, this is with the presence of family, the remembrance of God, and the preparation of the soul for its return to its Lord. And we must ask what becomes of that sacred space that the Sharia has prescribed when death unfolds not in the family home, not in a familiar bed, but instead amid machines and monitors and visiting hours. How do we navigate that? And perhaps the danger of our age is not those machines themselves, but the temptation they bring for us to treat death as a problem to be solved rather than a meeting to be prepared for, as something that is our decision rather than a natural and inevitable process. This is something that we will address this evening on this panel, and we have Dr. Zaidi with us who will be speaking to that. Now, these questions fall not only on the family, they fall on multiple groups of people. And all three of those groups are represented in this hall tonight. There are patients who are facing their final illness. There are families asked to decide for those they love. And then there are our Muslim doctors, nurses, and healthcare professionals who face these dilemmas not once in a lifetime, not once, but sometimes every single day. Inside, and this takes place inside institutions whose rules are not written by our fiqh, whose rules are not derived from our traditions, but are laid down by secular governments. And in a few minutes, we will hear from Dr. Sabra Kanani and Dr. Akbar Mitani, who will walk us through what these decisions actually look like clinically and what these terms mean. DNR, CPR, withholding, withdrawing. I will leave that ground entirely to them. And I'd encourage you to hold your questions about specific medical scenarios for the panel. But what I want to do is I want to talk a little bit about why we're holding this event tonight, of the journey that we've been on, that everyone on this panel has been on over the last year in terms of addressing these kind of questions. So our goal at the International Center for Advanced Islamic Research is to address contemporary issues like this through the lens of classically grounded Islamic scholarship. Because tonight is not about beginning a conversation, and it's certainly not about giving you the final answers. It is actually a progress report on a journey that is already underway. In April of last year, ICARE, the International Center for Advanced Islamic Research, together with our partners NASIMCO and IMI Canada, convened an Islamic Futures Symposium in Toronto at the Jaffery Community Center. And in the biomedical ethics stream, something quite remarkable happened. In that symposium, we gathered together medical professionals and religious scholars in the same room, in a closed forum, and clinicians were able to speak honestly about the cases that kept them awake at night, about the moral burden they felt when dealing with these issues of life and death. And the scholars listened. We had a room full of scholars listening to clinicians talk about their experience. And what emerged from this discussion, from this open and frank discussion, was a clear conclusion that the challenge facing our community is not simply a lack of rulings. It's not simply a lack of Shari'i rules governing these situations. It is actually the bridge between these rulings and the bedside. How do we take the moral imperatives laid down in the Sharia, in our books of fiqh, derived by our ulama, who are experts in their own field, and how do we apply this to the specific and urgent situations that take place in that hospital corridor, day after day? And so we set out to build that bridge between scholarship and lived realities in 3 steps. First, we compiled. Our researchers gathered together the relevant rulings of our maraja from their works, from the offices of these marajas' public responses. We translated them and we gathered them and we organized them by theme. What is the definition of death in Islam? What is life support, end-of-life interventions, medical liability, word for word, fully sourced? With no paraphrasing and no editorial hand, we established a baseline for what the tradition teaches. Second, based on that, we formulated a series of questions, and we were really fortunate and really blessed that 2 of our panel members here tonight, Dr. Iqbal Jafar and Dr. Sabra Kanani, took these questions to Najaf. They took them to the offices of our maraja. And Dr. Iqbal is a cardiac surgeon and Dr. Sabra is a palliative care physician. So I think I can safely say that they both deal with the possibility of death, in fact, the certainty of death, day in and day out. And they are the best possible people to speak to these realities. And I'm delighted that they were able to do this, and they actually went with a WF scholar based in Najaf, Sheikh Ja'far Farishta, who unfortunately couldn't join us here in Canada. But they sat down with senior scholars in Najaf and were able to ask these questions. And they did something that doesn't always happen in fiqh discussions, which is that they actually put forward real clinical cases. They said, look, this is what we're dealing with. These are the questions that arrive. How do we address them? These were not abstractions. These were not simple istifta'at. It was a detailed discussion around what goes on in the hospital, the actual dilemmas. And the third thing we did is we compiled the answers they got. And we've put them into a white paper, a research white paper that we're in the process of editing and revising, called Islamic Biomedical Ethics of End-of-Life Care, which maps question by question where the jurisprudence is clear and where clarification is still being sought. So what I'm describing to you, if you'll forgive all the jargon, is a process of research that we are undergoing. We are not simply asking questions from the office of the Maraja, we are engaged in a dialogue. Because what I've noticed personally, so my background is I studied in the Hausa, I studied in academia. I'm not a doctor, I'm not a physician. But what was apparent to me, listening to the scholars and the doctors talk to one another, is that they were all deeply concerned with people's well-being. That this entire discussion was 2 groups of people who simply wanted to look after the community, to do what was best for the people in this situation. But quite often, they were speaking in 2 different registers, 2 different languages. And getting them to speak the same language, and most importantly, to speak the same language to each other, was the method we wanted to, that was what we wanted to achieve. We wanted to open that dialogue. And we came away with a clear understanding of what sort of principles we should be applying here. That the obligation to treat comes from the need to bring benefit to the patient. And that the duty of rescue involves a rational weighting of the expected benefit to the patient versus the possibility of harm. And that when genuine doubt exists in that balance, that the patient's wishes all have to be considered. The sanctity of life is never in question in these cases, but what that means is to be determined case by case on principles. Now, I think I have to caveat this, because what we're doing is a work in progress. We don't have necessarily definitive answers on every question that will come up. We don't have new fatwas. All we've been doing is actually asking for clarification on the material that is already there from Maraja like Sayyid Sistani, may God preserve him. So I want to make that clear, that what you're seeing here tonight is not the finished product. It is not the end of our research. It is very much an update on our research. It's talking to you, the community, the people who this research is supposed to benefit, and getting your feedback. We are not here to deliver rulings. We're actually here, the reason why we wanted to do a public forum, because over the next 2 days we will have a closed forum again with physicians and scholars. The reason why we wanted to have this meeting is to actually hear from you all, to hear from your experiences, to hear your questions, to hear where you are on this journey. And I'll say this plainly, we could have waited until we had every single question answered before standing before you, but we chose not to. We chose not to do that because right now, as we're having this conversation here, there are families having that other conversation in hospital corridors all around the world. And we feel that it's important for us to engage with the community and to share what we know so far, so that hopefully, if you ever find yourself, or if you know anyone struggling with that sort of decision, that you know there are resources out there that can help you. So where is this headed? I want to wrap up now so I can hand over to the experts. Our goal is, with this white paper, to continue working on it so that we can eventually produce a comprehensive guidebook on end-of-life care from a Shi'i point of view, written for 3 audiences at once: healthcare professionals, patients and families, and the community leaders and scholars who will get those phone calls in the middle of the night from families terrified of making the wrong decision. Part of this guidebook will include things like decision frameworks and flowcharts for common scenarios, worked examples, resources for advanced care planning that align with our fiqh, and training for ulama and clinicians alike. But beyond this project is a bigger vision, and that is to actually compile faithfully, engage religious experts with real cases, and to build practical tools that can be turned next to still other frontiers in the field of Islamic biomedical ethics. We started with this question because in all of our discussions, this was the question that kept coming up when we spoke to the community. Because so many people have been dealing with this. I think on this panel there are people who have dealt with it. I myself, in February, my grandmother passed away, and I had to help my family make the same decisions. And I was really fortunate that I could pick up the phone and speak to Dr. Matani and Dr. Iqbal, who both provide me with not just a lot of support as my friends, but I think were also able to give me great medical advice in terms of what was happening with my grandmother. And once I understood that, it made making the right decisions so much easier. And as I said, I just want to emphasize again that this is, that a big part of this, though, is speaking to the community, is learning about your experiences, learning about your questions. This event isn't a courtesy. This is actually an essential part of the research process, engaging with the wider audience. So let me just map out what's going to happen this evening. In a moment, I'm going to invite Abbas Bhai Bandali, the president of NASIMCO, to say a few words talking about NASIMCO's involvement. And then I'll hand over to Dr. Akbar, who's the president of IMI Canada. And once again, I want to thank both of their organizations for the superior support they've provided to this work from day one. Then we will have presentations by Dr. Akbar and Dr. Sabira, and also then by Dr. Said Nasser Zaidi. He will speak on the subject of spiritual healthcare at the end of life. However, the heart of the evening will be the panel and open forum where the presenters are joined by Dr. Jafar, who I've already introduced, and also Sister Sabiha Bandali, who's got extensive experience in the psychosocial aspect of this with the community. Then the microphone belongs to you. You can ask questions, you can share your thoughts and insights and experiences. We will close in time for congregational prayers. I believe Maghrib is at 9:43. Is that right? And I just want to close with this thought, underscoring the importance of this, that, if you look at the culture in which we live, the dominant global culture now, it treats death as the worst possible thing that can happen to anyone. How many of you have seen the film Bambi? We all know the scene I'm talking about, when Bambi's mother dies. In any film you watch, the death of a loved one is treated as the worst possible thing that can happen. Death is treated as an end. It is treated as the annihilation of the person. It is treated as the final goodbye. That is how we are being trained to view death by the dominant global culture. But that is not how Islam, and especially the Islam of Ahl al-Bayt, see death. We're told in the Quran, كُلُّ نَفْسٍ ذَائِقَةُ الْمَوْتِ. Every soul shall taste death. But what is death? What is death? Amir al-Mu'mineen alayhi salam puts it beautifully when he says that death is merely a transition from one abode to another. Death in Islam is not an end, it is a threshold. And the Quran speaks about the human soul, the believing soul, standing at that threshold as an-nafs al-mutma'inna, the tranquil soul, the soul at peace. And so the work we present this evening to you, the topic that we are addressing this evening with you, has one aim: that no family in our community should ever have to stand in that hospital corridor confused, afraid, and alone. That they should stand there, even in their grief, even in the hardship they're going through, in a state of itminan, in a state of being tranquil and at peace with their Lord and at peace with their decision. And so, with that, I'd now like to hand over to our next speaker. Please, can you join me in welcoming Abbas Bandali, the president of Nasimco, to the podium with a loud salawat ala Muhammad wa ali Muhammad.
Bismillah ar-Rahman ar-Rahim. Administrators of Az-Zahraa, Sama'at Sheikh, distinguished panelists, respected guests, Assalamu alaikum wa rahmatullahi wa barakatuh. Death, dying in Islamic death, butter chicken. I thought that was sending a message. That would be the perfect Islamic death. I'm joking. I know this is a serious topic, and I just am going to take 2 minutes of your time. This is a great opportunity, and I'm so humbled to be here to participate in this discussion. What Sheikh Khalili just explained, I want to just connect the dots and demystify two things. Number one, Sheikh Khalili very eloquently explained the role of a scholar and academic, and then the role of a physician. Right? So we have Akbar Bhai and Sheikh Khalili here representing those two spheres. One of the reasons that I'm sitting over there is I'm on your side. And what I mean by that is I'm putting pressure on them, because we need this done yesterday. Every day that we sit and just talk, we need answers. And so Nasimco's role, and that's the second point I wanted to make, is what is Nasimco's role in all of this? As the academics and the scholars are researching and talking to the physicians to try and understand the challenges, Nasimco is trying to put it together, and we're collaborating with IMI and iCare under the World Federation, our parent body, to quickly get us some guidance, quickly get this white paper into booklets that we can then distribute to all the centers, all the Shia centers in North America, because every day people are facing these decisions, as Sheikh Khalili said. So Nasimco's role in this is to try and glue it together, bring some of this information out there, and then publish it, and then distribute it, and then make a channel where we can have, this is an ongoing process, right? We learn a little bit, and inshallah we'll extrapolate and learn more. So we'll keep the dialogue going, and since Az-Zahraa is a member of Nasimco, we have 24 members, we are receiving these inquiries from several centers. So Nasimco's role in this, and my hope, is that we can quickly get something produced from this, disseminate it with the community, and then inshallah expand and allow for more questions and answers. That's all I had to say. I don't have a speech or anything. Assalamu alaikum, and I hope we all benefit from this. Assalamu alaikum wa rahmatullahi wa barakatuh. Should I invite? Please invite.
Now could I invite Dr. Akram Matani, please, to come to the podium and say a few words on behalf of IMI Canada. Please join me in welcoming him with a loud salawat ala Muhammad wa ali Muhammad.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Respected scholars, elders, brothers and sisters, Assalamu alaikum wa rahmatullahi wa barakatuh. Obviously, the community knows me here very well, so I'm wearing a very different hat today with respect to the community as the president of IMI Canada. IMI stands for Imamia Medics International. And I just wanted to give you a little bit of an introduction on IMI and what Abbas Bhai said about Nasimco. A very large part of the work that we are doing is exactly what was outlined by Sheikh Alex. I don't think Sheikh Alex actually introduced himself. I think that he was probably being a bit too humble, but you probably don't realize what an outstanding scholar he is. And his leadership in eye care at the International Center for Advanced Islamic Research has been monumental. There are many spheres that this particular center is doing research on, including artificial intelligence and education and cryptocurrency and whatnot. The bioethics is one part of it, which is the part that obviously IMI Canada is actively engaged in and very interested in developing this guideline and toolkit for the community, the healthcare professionals, the scholars, and the leaders of the community. I also want to just say that I want to also talk about IMI Canada as an organization that also is focused on health and well-being, not just on death. We are very much focused on the health and well-being of our communities and across Canada. It is the area where we want to actively participate and collaborate with other organizations like Nasimco. There are many communities, Shia communities in Canada that do wonderful work, but they're woefully short when it comes to a health and well-being agenda. And so we don't want the wheel to be reinvented. What we want to do is to collaborate and be able to go into communities and talk about the importance of prevention as an important part of health and well-being. Mental health is another very large component of the work that we are wanting to do in communities across Canada, and also around addictions, which is an area that we are constantly being asked to look at by various communities. So we hope that over the next few years, a couple of months, that we are able to come to communities. We've already started this, especially in the East, with many different types of workshops and collaborating with different organizations around mental health, around addictions, around psychosocial issues, dementia, depression, all of those kind of different things that we really want to focus on. But also the most important preventative health aspects. So that's also a very important role of what IMI Canada does. But this session today is particularly important for us because of the fact that I think almost, I would say at least once a week, if not more often than that, I get called by people from our communities across Canada to help them with the decision making around end of life. And a lot of these cases are really tough. We've recently just had a couple of deaths in our own community over the last couple of weeks. And you know that we've had to deal with, Sheikh Salim was involved in it, Maulana Nasir was involved with it, and we have, particularly with Maulana Nasir, we've been working together in these very difficult scenarios on an ongoing basis. So I'm really excited to get this work done. I think Iqbal Bhai and Sabira Bhai, we're all been together in this journey, and there is a little bit of a light at the end of the tunnel here that I think will really get to it. But I hope you will be able to participate today and give us more food for thought as we do our session tomorrow with the healthcare professionals and the ulama. So with that, I thank you all for coming today. IMI Canada is proud to be part of this whole journey and process, and we hope to do a lot more in the future. Thank you so much. Bar Muhammad wa ali Muhammad salawat.
Thank you very much, Dr. Akbar, for that really insightful introduction to the work that IMI does. And I think, I just want to sort of underscore what Dr. Mantani said about sort of well-being and health, that it's not all about death, it's also about getting you there in the best possible condition. There's so much. It's good that we can laugh about death. Just a little bit of lightness. I just want to make one thing clear as well. I said that iCare is based in London. I just want to make clear that is London, England, not London, Ontario. And I would just like to ask Prime Minister Carney to maybe look into Canada's naming conventions, because it's very confusing. So I work in London. I live near a place called Windsor. Again, that's Windsor, England, not Windsor, Ontario. I also grew up in Surrey. That's Surrey, England, not Surrey, British Columbia. I really, I love the fact that you Canadians didn't kick us out like your cousins south of the border, but we really have to talk about the naming conventions you have going on, because it's very hard to introduce myself. Usually the accent is a giveaway, though. That and driving on the left side of the road. Just a quick story on that. I was pulled over in Toronto because I was on the left side, and then I moved to the right, and I saw the lights go on behind me. The officer walks up to my window and rolls it down and says, "Sir, do you know why I'm pulling you over?" I said, "I was driving on the wrong side of the road." And as soon as he heard the accent, he just burst out laughing. And he just waved me off. I think it was Sheikh Salim that pointed out that may have gone very differently if I was visibly Muslim. Fortunately, I had my cloaking device on. So now that we've got all the humour for the evening out of the way, we can get back to more serious topics. So I would now like to invite Dr. Sabra Kanani and Dr. Akbar Mantani to deliver their presentation, which is setting the context of end-of-life decision-making and the key terms that involves. Because I think we all find that quite confusing. We've got things like DNR, CPR, withdrawing treatment. So I'd like to invite them to do it. Are you both going to? Are you going to sort of be alternating, or do you have sort of a half and half presentation? Oh, they're doing a medical consultation right now. You're going to start. Okay, we're being progressive, and the ladies' side is going first. We hope that we hope to balance that out in the questions. We want to hear from everyone. Are we ready to go?
Yes.
Okay, Bismillah. Please welcome Dr. Sabra Kanani to the podium with a loud salawat ala Muhammad wa ali Muhammad.
You put it up there, I'll fix this. He's going to do it. There. That's still too high.
That's too short girl problems. Assalamu alaikum, everybody. So I don't want to take much of everybody's time. I just want to go through terms that medical professionals use that we're going to hear a lot about today, tomorrow, kind of over the coming days. I want to make sure that we're all talking in the same language. So I really want to just spend a little bit of time going through the terms and just making sure that we all kind of are speaking the same language and we're all on the same page. So, as you know, we all kind of hear the same things. We kind of want to talk the same language, but we're talking different things. Sometimes doctors speak one language, families are saying one thing, but interpreting it a different way. So we really want to make sure that we're all having a conversation that's meaningful to all of us. And, people use different terms, and we kind of need to understand kind of what these terms mean. You might hear things like palliative care, hospice care, end-of-life care, comfort cares. And, people still assume that palliative care means end-of-life care. It really doesn't mean end-of-life care. What we kind of aim to do in palliative care is to improve a person's quality of life. No problem. So we aim to improve a person's quality of life throughout their disease journey. So I see patients right from diagnosis right until the end. Sometimes I follow patients for years at a time. So we're really not just talking about a journey at the end for the last few weeks, for the last few months. We're talking about a person's journey right throughout. And we know there's decisions and questions that come out throughout their journey, and it's really important that we kind of understand. Hospice care here in Canada typically means kind of end-of-life care, usually in the last 3 months of life. And that's usually focused on quality of life and symptom-based care rather than active medical treatments. And you know, when we talk about kind of palliative care and end-of-life decision-making, we really want to focus on a few things. We want to talk about kind of what the person's goals and values are. We want to understand the medical situation. We want to discuss the treatment options. We want to understand their family, their culture, their spirituality, and you know, what their rules are. And that helps us make a care plan. And that's really what we're kind of focused in on today, is we want to bring everything together to make sure that we're all making the right decisions. Now I kind of want to go into some of the terms we'll kind of hear. Nutrition is a big thing that comes up. I would say often I get calls about nutrition and what's allowed and what's not allowed kind of at the end of life. So there's kind of different things you may hear. Some people talk about oral intake, and that's kind of what we can take in by mouth, eating, drinking. Then there's things like assisted feeding, so where somebody has to help somebody feed. So you might see somebody like a patient who has dementia who needs help being fed. Then there's comfort feeding, and that kind of, we often talk about that at the end of life where, you know, there might be risks associated with feeding someone, but, you know, they're wanting food, so we're allowing them to eat for their own comfort. There's kind of terms you may hear called like dysphagia, where they have trouble swallowing, aspiration that doctors often talk about, where food goes into the lungs. Or you might hear things like cachexia, anorexia, and that's kind of where, you know, somebody has an illness that means they have a low appetite, they're losing weight, they're losing muscle mass, and it's really a marker of somebody getting more and more ill. So these are some of the terms you'll hear around in nutrition and feeding. So, you know, then we kind of talk about artificial nutrition. So what you'll hear are things like tube feeding. So you might hear something like NG tube feeding or PEG tube feeding or G tube feeding, or you might hear things like TPN or IV nutrition. And you know what? These are all kind of different types of feeding that might or be offered at some point during a patient's journey. So NG tube feeding is where the feeding tube goes through the nose, down the back of the throat, into the stomach. And then the kind of food, liquid nutrition goes into the stomach. A PEG tube or a G tube is where it's a small surgical procedure where a tube is inserted directly into the stomach and comes out through the skin, and then the feeding goes straight in through the tube. When we have kind of J tube feeding, again, it's a little bit more invasive and it goes deeper into the person's bowel, so that's even more of an invasive procedure to be able to kind of achieve that. Then you might hear something like TPN or IV nutrition, and this is kind of IV nutrition that has to be inserted through usually what's known as a central line or a PICC line, which is kind of an IV line that goes directly close to the heart, and then the nutrition is delivered that way. And, you know, these different types of nutrition may be offered in different circumstances. I wanted to talk a little bit more about kind of artificial kind of hydration as well, because a lot of times I get questions about fluids and, you know, should we continue IV fluids or intravenous fluids? And, you know, what does that mean? Kind of, you might hear words. So IV fluids are fluids specifically through a vein. And, you know, sometimes they can be helpful in certain situations, but they get to a point where actually they may cause more harm. Another term you may hear is hypodermoclysis, and this is actually IV fluids given under the skin, drip, drip, drip under the skin. Sometimes we use that in hospice care if somebody may benefit from IV fluids. And then often at the end of life, we talk about mouth care a lot, and mouth care is really important. It's about kind of keeping the mouth moist, the lips moist, to decrease the sensation of thirst. So these are the types of things we talk about in kind of hydration terms. And then I want to pivot now to breathing, and that's kind of a big issue, kind of oxygen and breathing support. You might have oxygen delivered through kind of the first picture where it's kind of prongs in the nose. That's kind of the most basic form that oxygen is delivered in. And then we can kind of go up a ladder where we're getting more and more invasive in how we're trying to deliver the oxygen. We can give oxygen through the nose, but in what's known as high flow, where it's high pressure to deliver, basically push the oxygen deep into the lungs. So that's another form of oxygen. Then you go to even more pressure. So we have that mask pressure that you might hear terms like CPAP or BiPAP or non-invasive ventilation. And then it's the kind of typical kind of life support that people know of, where we call it kind of life support or kind of a breathing tube, or intubation are the terms you may hear, where we're putting a tube down someone's throat and using a machine to control their breathing. So these are all the different types of ways that oxygen can be delivered. So I think I've gone through pretty much all of this. Next thing I want to talk about is resuscitation and code status, or things like you may hear, like CPR, DNRs, kind of what do these terms mean? You might go into the hospital and somebody may ask, do you want your loved one to be a full code? What does that mean? Typically, people think of that as we're going to want everything done for them. So we want all medical treatments done for them. If their heart were to stop, if their lungs were to stop, we want to do the chest compressions, we want to shock the heart, we want to put a breathing tube down, we want to send them to the ICU, we want to do absolutely everything possible to keep them alive. You might hear another term. In Ontario, we use the term allow natural death. I think here we use kind of do not resuscitate, is that right? They basically mean the same thing. I actually prefer allow natural death because I think it actually kind of speaks to what we're doing, which is allowing a natural death. We're not, if somebody's heart stops, which somebody's lungs stop working or stop breathing, we're actually allowing the natural dying process to take place. So DNR, A and D, they mean the same thing. And then, it's a spectrum. And, it's not just all or nothing, which I think people think that, it has to be. It is a spectrum. You can say things like you want to continue some medical things, but not continue other things. So you might hear terms like, do you want to continue active medical management? Or we want to continue what we're doing now, but not escalate beyond what we're doing now. So you'll hear those terms used by medical professionals as well. And then it may get to a point where, you decide you want to focus on comfort and end-of-life care when someone is close to the end. So when somebody's saying, okay, this person is comfort measures, we're focusing on caring for them, managing their symptoms, making sure that they have quality of life for whatever time is left. So I think I've kind of alluded to this, but we'll kind of go through it. So DNR doesn't mean do not treat. It's just a different form of care. So we're not doing things like the chest compressions. We're not doing shocks. We're not kind of following a CPR sequence. What we are doing is we still may be doing medical care, but we're providing other forms of treatment. So we're still providing care. We're not doing nothing. We're just not doing that one aspect of care. And I think that's it for me. Dr. Mithani, do you want to add a little bit? Sure.
So between Sheikh Alex and Dr. Sabira, you've covered most of it. I just want to give you a little bit of the BC context so that you're just expand on this. When you go into, when your loved one or yourself go into the hospital, or whether you go into a long-term care home, long-term care facility, assisted living, the healthcare professionals may ask you to engage in what they call a goals of care conversation, right? Or sometimes it's called a seriously ill conversation. And that is exactly the conversation that Dr. Sabira talked about, is to really determine what is your goal, right? What is it that you want to achieve for your loved one if they are, for example, not able to give consent because they may be unconscious or they may have dementia, that they can't actually make decisions for themselves. And the family will be engaged in that. Of course, if there is a patient who can make their own decisions, then the healthcare professional will defer to their decision regardless of what the family thinks. It's really important to understand that, because you may want something for your loved one which your loved one may not want. And the healthcare professional legally is obliged to listen to, or vice versa. Exactly. Thank you, Iqbal. Yeah. So, so you have to be really careful when you're having these serious, what they call goals of care conversation or seriously ill conversations. One thing I want to just emphasize is that the healthcare team, if you have what we call advanced planning processes in place, advanced planning guidelines in place, where you have actually had a discussion with the family has sat down, they've had a discussion, your loved one has clearly articulated that this is what I would want in the time that if this happens to me, I would want this intervention. I would want to be a DNR or A&D or whatever, that I do not want somebody to jump on my chest and do compressions, because at certain point, depending on the frailty of the person, how frail they are, what kind of irreversible end-of-life diagnoses they may have, these things may actually be futile, and we will talk a lot about that, about what is futile or burdensome and so on and so forth. So you want, the more clarity you have for the healthcare professional, the easier it will be for you when having those conversations. A good healthcare professional will ask you this question. If your dad or mom, if they were able to talk, if they were able to communicate, have they ever told you what would they have wanted in this situation? That's the first question they will ask you. They're not going to ask you, the first question is, can you tell me what you want? Or can you tell me what your faith wants? It's not the first question that they will ask. Right? Now, a Muslim doctor, if you're fortunate enough to have a Muslim doctor, or if you're fortunate enough to have a spiritual care practitioner like Maulana Nasir, then the conversation will change, because he's going to be able to help you, and the Muslim physician may be able to help you. But otherwise, the team is going to want to know, what would my patient want more than anything else? So what I want to emphasize is the reason we're having this symposium is so that you actually start having those conversations at home. And if you can do advanced care planning, and there is a process for advanced care planning, you can actually have, proper documentation through lawyers and so on and so forth. That's very clearly, it's called a representation agreement. I don't know what it's called in Ontario, but here they're called representation agreements. You put a representation agreement in front of a healthcare professional team, it's done. They will follow that because they are legally obliged to follow it. Now, obviously, representation agreements don't do everything, every type of scenario, but it really does help. So seriously ill conversations, goals of care conversation is one thing. The other thing is they're going to talk to you about what we term here as a level of intervention, right? So I don't know, Dr. Sabira, what levels you use or what the terminology is in Ontario. Here they're called levels of intervention. So they will probably say, at the end of the day, they will want to label the person as a certain level of intervention. And they're called MOST, M-O-S-T, right? The medical orders for scope of treatment, right? Post, the same type of a thing. Yeah. Now, MOSTs are actually technically a physician prescription, to be honest with you. And it's based on your goals of care conversation. So, for example, a level 1 may be here, comfort care, which means that, they're going to focus on comfort care for your loved one or yourself. And a level 3, is usually a do not resuscitate. Level 3 means do everything other than ICU, mechanical ventilation, so on and so forth, right? And then there is, like, Dr. Sabira mentioned, full code and all of those things. So just be cognizant. Sometimes when you're sitting in these, hospital corridors, as Sheikh Alex talked, it's actually, this is what actually happens in real life, right? You may be, you may be exposed to all these different terminologies, and the more you know about it in advance and the more you have prepared, the easier your conversation will become. I just thought I'd add that. Just for the
Thank you very much, Doctors Kanani and Matani, for that very insightful presentation on providing the medical context and demystifying some of the terminologies that we encounter in these situations. I just want to ask, can we express our appreciation to them for that, for the clarity that they bring to this discussion with the loud salawat ala Muhammad wa ali Muhammad. Before we move to our next speaker, just two traditions of the Prophet and his household, salawatullahi alayhim, came to my mind. The first is actually a hadith I remember from Abu Abdullah al-Husayn alayhi salam. And we've just gone through the experience of the 10 blessed nights of Muharram, and remembering the struggles of Abu Abdullah. So it seems really appropriate to share one of his reflections on death, in which he said very eloquently that death hangs upon the human being as a necklace hangs around a young girl's neck. Just ponder on that image for a moment. The image of a young girl wearing a necklace. Imagine one of your own children, wearing an item of jewelry. It seems like the most natural and innocent thing imaginable, but from the moment we are born, the reality of death hangs upon us. And then I remember another much more well-known tradition from the Prophet and his household, in which we are admonished to plan for this life as though we are going to live forever, and to plan for the next life as if we were going to die tomorrow. Dhikr al-Maut, remembering that we will die, is actually one of the most praiseworthy principles of Islamic ethics. It is, in fact, the foundation of all Islamic ethics, the fact that we will one day die. In fact, I would argue it is the foundation of all ethics, whether Islamic or otherwise. In fact, there was a practice in ancient Rome that when a victorious general returned from a campaign, they would throw something called a triumph for him. And the triumph was basically he got to be king for a day. So he got a celebration in his honor, celebrating his great victories for the Roman Empire. However, during that celebration, there was a man appointed to follow him around and every so often whisper in his ear, "Remember that one day you will die. Remember that one day you will die." And I think that we could all use that man following us around whispering in our ear, "Remember one day you will die." And I think that's really relevant for this conversation, because if we are believers, we are told that we should go to sleep at night with our will, with our wasiyah under our pillow. In other words, death is not simply something that we must prepare for spiritually, not something we must merely prepare for ethically and religiously. It is something we must prepare for practically. It is, in fact, a grave injustice to your loved ones and to your family and your dependents for you to die without a will, because you're essentially passing that burden onto them. And your will isn't just about, "Oh, I want you to divide up my estate like such, here is my 1/3 and so on. It's also about detailing your debts, your missed obligations, giving them the peace of mind knowing that they have taken care of all of your needs and wishes in this world and the next. And I think we need to add to that your advanced wishes with healthcare. So, we all have elderly parents, relatives, friends, people who we know are maybe facing that situation. And all of us, in fact, may face that situation unexpectedly. It just takes messing up one turn right on red, as I often do, because we don't have that in the UK. So I do a lot of dhikr al-maut when driving in Canada, and I think everyone, as maybe Dr. Iqbal and Dr. Sabir and Ali Mehdi, who drove with me, came with me in my car today, I think they can attest to all of my passengers do dhikr al-maut as well. So it just takes one Englishman driving in Canada for things to go very suddenly wrong, or for you to be meeting your Lord sooner than expected. The appointment is brought forward. You may not receive the calendar invite. The point is, though, that these are difficult conversations. No one wants to say to their loved one, no one wants to say to their grandmother or grandfather or parent, listen, what do you want me to do in that situation? What are your wishes? No one wants to sit down. But this is something I think that applies both to wills and estates and to end-of-life care decisions. I just want to really underscore what Dr. Mintani says, that this isn't simply a practical requirement that we should be looking at. What the advice that Dr. Mintani is giving is not simply good practical advice from a medical professional. It is, in fact, the Islamic position on death, that you should be ready for death. And part of being ready for death is making sure that your loved ones are ready for your death. And so do not delay these conversations. Do not shy away from them. It can be difficult, but there are professionals who can help facilitate that, as you can see here tonight. And I think that ties nicely into our next speaker, who we're very fortunate to have here today, Dr. Said Zaidi, who is going to be speaking about the spiritual aspects of end-of-life care. So please can I ask you to welcome him to the podium with a loud salawat ala Muhammad wa ali Muhammad.
Auzu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. Respected brothers and sisters, scholars and healthcare professionals, Assalamu alaikum wa rahmatullah. I'm going to talk about the role of spiritual care at the end of life and the importance of spiritual health and the meaning of spirituality. And whatever I am speaking today, this is not my conceptual knowledge. This is just my experiential knowledge. So I am experiencing this in the clinical setting and experiencing at the end of life, palliative cares, hospice, and long-term cares. So whatever I'm mentioning here related to my personal experience as well. And also I'm also including my conceptual and theoretical knowledge as well. So first thing that I want to mention here, the religion and spirituality at the end of life stage or situation. So I'm separating religion from spirituality because religion is one of the ways of spirituality that we are expressing our spirituality through our religion. So if, for example, someone is religious, someone may not be religious. Someone may not be religious but believing in God. So different kind of people are there. And if, for example, they are not believing in God, so again, they are spiritual. They may be spiritual. So religious, but if you are a religious person, if you have religiosity, if you are believing in God, then it means you are making our work very easy. I mean, you have a strong spirituality as compared to those who are not religious people. They have spiritualities, but their spirituality is more related to this worldly life, this materialistic life. So when I'm talking about religion and spirituality at the end of life, I mean spiritual religious care. I'm not talking about religious services that we are providing in the centers and mosques. Religious care is very different from religious services. When we are providing religious services, we may not be paying attention to the impact of our speech. Whatever we are speaking to our community, we are not paying much attention how people are perceiving my speech. Maybe it is negative, maybe it is harmful, maybe it is good and positive. So I'm not paying much attention about this one. But when I say that we are also providing religious care and spiritual care, it means that religious care means when I am providing religious care, I care for my patients. I care about my patients. This is very important for me. How I am impacting my patients, and I am also I am paying attention and monitoring my progress as well. So effect of my spiritual care service is very important for me, and religious. This is why this is very important to understand. The other point is when we see practically, for example, I'm providing spiritual care to all kind of patients, and in every department I have to go Vancouver General Hospital or Fraser Health. But at the time of like when we have an end of life situation and stage, then spirituality and religion is playing very strong and very important role. Even you know that this distance is important. For example, now you come to know that doctor has disclosed the information that you are going to die, and maybe in few days, in few weeks, or in few months. Sometimes really we don't know when this person is going to die. But sometimes this is part of the strategy not to say to the patient's exact time of death. So when we are, for example, doing this one, people who are at the end of life stage, they feel meaninglessness in their life, because these few months are very important. How you are going to spend these few months, because you are not, there is no meaning in your life, there is no purpose in your life, and then it is very difficult and really hard time for the patients. So I have noticed and I'm experiencing all the time that at the time of at the end of lifetime, even those who are not religious, who never practiced religion, who might be religious but never they are not practicing like religious people, but at the time of death they turn towards spirituality and religiosity. They want to know so many questions. They are asking questions. What is the meaning of suffering? What is happening to me? What do you mean by afterlife? So they are curious about this one. They really want to know. And they have heard a lot about religion, religiosity, spirituality, believing in God. So everyone knows this one. So they need to know more about this one. So playing very important role. And when they are really hopeless of medicine side of the treatment, they know that cure is no more possible, but healing is still possible. Comfort is still possible. Peace of heart is still possible. So this is why it is very important for us. So religion and spirituality is helping us to navigate our experience and see how to find meanings, whatever time is left for us. I remember there was a lady, 2-3 times it happened to me, and they were very, showing their vulnerability, and they were weeping and crying. And they're saying that I'm just waiting for death. I can't do anything. you can see my situation. Physically, I cannot move. So this is the situation. You are just in the meaning, you don't have meaningfulness in your life. So religion and spirituality is always helping us a lot. But sometimes patients are giving a lot of challenges to us. You know, I remember that there was a lady, she was very sharp, very intellectual, and she was just putting me on very tough situation. And she said that, I want to die and you want to make me alive. Why you are doing this one? So, you know, sometimes it is very hard for us to stay in the moment. Our situation is very crucial, very difficult. People are grieving, people are in sad, they are shedding tears, families around. The person is dying. And in this situation, even sometimes nurses and other our professionals, they want to push us to go inside. Yeah, because it is very hard. So then we have to deal all these kind of, and then lot of important questions are there. They're asking about suffering, they're asking about forgiveness. I remember there was a lady and then she was just dying. She was young also, and I was traveling, and then her husband was keep contacting me. I was in California, somewhere else, and then I was not able to come back in time. And then when I came back, she just died. But I met with children, and they were in the hospice, Fraser Health. Children, adult children, they were asking very difficult questions. And I was really inspired. And then they wanted to ask that our mother was always giving, serving God and then offering prayers, and she was very religious, and she was always helping other people. Why God has done this to our mom? So this is something. But the husband told me when I asked what actually she wanted to ask me, is there any specific question, for example? Then he said that she was very desperate to ask this question, what kind of prayer I should ask God? What should I ask God in this situation? Should I pray something for this world or for the other world? So I'm going there. So again, this question is very challenging when you are in the situation and then you are providing your spiritual care. So these kind of things are always there. If we are not addressing these existential questions, I'm saying existential questions which are related to our purpose, which are related to our meaningfulness, which are related to deepest level of our heart and our soul, then there will be a spiritual distress for those who are going through this end-of-life situation. So what is the spirituality? Spirituality is actually inner strength and our sources of our strength. But as a spiritual care practitioner, we have lot of inner strength, but we may not know about our strength. And then if even we know our strength, we may not be connected to our strength. So many Muslims I have seen, they are really very scared of death. They are very fearful, fear of death, fear of process of death, fear of unknown. And then they also believe in God. They're always praying. Why they have this fear of death? So sometimes this is happening because most of our belief system is in our mind. I mean, when we have theoretically we say we believe in God, we believe in prophets, we believe in imams, we believe in hereafter. So many things are very theoretical in our mind. But God is not in our life. When God is not in our life, and we are very solid and strong religious people, and we say that, oh, we believe in God, we are Muslim, but God is not in my life. I'm not feeling the presence of God in my life. I'm not realizing the presence of God. And then this God is not helping me at the time of suffering, at the time of end of life. And our preaching system is also, I would say that this is not right. Because when we are young and we are listening to our speakers, some speakers are always talking about punishment of God, about hellfire, and they don't understand that they are creating fear in our heart, which is going to our unconscious mind. And we are not talking at all about the mercy of God, forgiveness of God, compassion of God. And these verses are very, very strong in the Quran, although they are very limited as compared to the verses which are related to punishment. But qualitatively, these verses are very strong. La taqnatu min rahmatillah. This verse is also. So spirituality is related to our inner strength. And we have, as a Muslim, we have lot of strength. We have lot of sources of strength. For example, suffering. When you are suffering, then your sins will be forgiven. And if you are observing patience, and if you are, for example, thankful to God and you are submissive to the pleasure of Allah subhanahu wa ta'ala, then not only your sins will be forgiven, but you will be given sawab, you will be given reward, because reward is given on whatever you are doing willfully with your ikhtiyar. If your ikhtiyar is not there, I don't know sawab is there or not. But if you are suffering, if you are sick, you are ill, you are at the end of life situation, then actually it is inevitable for you. You are just suffering, you are becoming ill and critical illness. But when you are observing patience, patience is very important. You are doing something. Your perspective is different towards your illness. Now, this is strength for us. But it doesn't mean that we have made this strength for ourselves or not. This is more important for us. We may know we are reading theoretically always and listening from our speakers, but how we can make it for us as a force, motivational force, as a inner strength, so that we can overcome our crisis and our suffering. Other thing is spiritual care at the end of life. We are searching and exploring, and we are making our assessment. And then we are not imposing anything. Several times it is happening, all the time it is happening. I have very deeper understanding, deeper approach. Patients who are Christian, Jew, and Buddhist or Muslim, they have wrong understanding about so many things. I am very calm and quiet, and I'm very comfortable. I don't have any problem. I don't want to impose anything on them. I want to find out their own strength. It is very important for me. So what they already have, and then I dig them, and I explore them, and I search them, and then I see that how much they are connected to their God. And then I see that they are not connected to this one. So then I am helping them. And sometimes they have different kind of strength. I remember there was a patient who was just dying, not dying, but stage 4 cancer. And he knows that he's going to die. But he was Christian. And I made my assessment. And I came to know that one issue is really very important for him. He's weeping and crying. Sometimes, at the end of life, people are weeping, crying, they are very desperate. But we are thinking that because they are dying, they are doing this one. Actually not. They are worried, or they are worried about something else, not about themselves. So they have maybe family issues, some other issues. They are not worried about their death. They are not scared about their own death. So I noticed that he's really crying a lot for his wife 6 months before she died. And then I said that, okay, and further I explored, and then I came to know what he's thinking is very important, And he said, if my wife was alive, she would support me. She would help me. Nobody's there to support me. Support is also very important. Sometimes we are strengthening the family members around. They are coming to see their patients, especially Muslims, but they don't know the value of their support. They don't know the power and the strength of their support. Sometimes they say that, oh, end of life, dementia, they are disconnected, they don't understand who is around. This is not the right thing. They may not be able to speak to you, they may not be able to have non-verbal cues or something like that, but they still have feelings and emotions. So feelings and emotions are still there. So this is why we see that we are facilitating them, we are connecting them, and very important thing which is distinguishing us from other healthcare professionals like social workers, psychiatrists, psychologists, is that we are trained to establish a heart-to-heart relationship. It is very important. If we are able to, then patient is not thinking that we are here to doing our job. We are not. If patient has this experience and perceiving like this, then there will not be any effect. But if patient knows that there is a real and genuine compassionate presence for them, genuine active attention and deep listening, then it's very different. And when we want to establish heart-to-heart relationship, there is whole psychology behind this one, how to do this one. Then we have to, one aspect is that we have to pay attention to our own experience. And then we have to see what are the common grounds between me and the patient. And then I have to go to see that when I was grieving, when I was sad, how I was feeling and how my emotions were. So all these things were important for me. So this is another thing that which is heart-to-heart relationship in spiritual health. And then seeing a whole person. Yeah, so a whole person is important, that when we go to see patients, we are not seeing as a disease or as a diagnosis. We are seeing as a whole person, and then they have relationships, they have achievements, they have accomplishments. So all these things are very important. Only just wanted to give you the main points. Communication gap. This is what we are helping a lot to the doctors, medical team, because there is a big communication gap, because the time has changed now. Lot of people who are coming from different cultures, diversity is there. They have different ethics, they have different norms. So it is very difficult for our medical staff to really understand what they are thinking. If you are just saying, because patient that you are going to die, for white people, they are able to say, and this is part of the code of ethics also. But if you are saying this for example, those who are coming from Iran and some other countries, they will see harsh reaction, very harsh. And I have seen that they have created a lot of problems for the system. So this is why the palliative nurse was saying to me, oh, she's at denial, this lady, the young lady who was just dying. She's at denial. I said, no, she's not at denial. She knows she's dying, but her culture doesn't allow her. The doctor is directly saying to her that you are dying, something like that. So we are working on these kind of issues. So thank you very much. So we will be, inshallah, in touch. We have a lot of things to discuss tomorrow and day after tomorrow. Assalamu alaikum wa rahmatullah.
Thank you so much, Maulana Dr. Zaidi, for that really insightful presentation on the different dimensions of spiritual care at the end of life, which actually looks not just at sort of spiritual care for Muslim patients, but spiritual care holistically, which I think is something, in a conversation today, actually, I was having with educators at the school, someone offered the insight that increasingly we're realizing that the foundation, one of the key foundations for good mental health, for good mental well-being, is having that sense of purpose in life, having that spirit, having that sense of the spiritual, and so that's becoming increasingly important. We're now going to move to our open discussion where we want to hear from you, the audience. However, I'm also conscious that to my right we have tea, and to my left. So I'm feeling somewhat surrounded, and as a tea drinker myself, I think we owe you a 5-minute break so you can gather your caffeinated beverages and come fully energized for the forum discussion. So we will break now for literally 5 minutes. In fact, if we can make it 2 minutes, that would be perfect, so that we'll have a full hour for discussion. Salawat ala Muhammad wa ali Muhammad. They really going all out for us. There's two, so they can go.
I'm just going to use the washroom.
Thank you so much for your Quran was lovely. It was lovely.
Doctor, how are you?
Tomorrow in the morning, we'll start in about 1 hour.
I'm sure we will.
Yeah, inshallah. Today I just started.
Yeah. Yeah, I love it. Yeah. Yes. And do not give nicknames.
Yes.
My father loves to quote that verse.
Unfortunately, right now,
COVID was on.
Yes. The natural focus has been so valuable to us.
Courses on
Yes.
no help. Help doesn't mean just help me financially. 5 million Jewish.
We don't do that. You're right. You're right. We don't do that. Oh yeah. Yeah. Do you want some tea?
Nice to meet you.
They're from England. Where in London? No. They're from England. Yes. Toronto. Cardiologist. Heart surgeon. Heart surgeon. Hamilton, but I think Sheikh Morton is from. I think where are you going now? I don't know yet. I'll be seeing him inshallah. We're looking for a new place. Yes. So tell him to come to the symposium.
Up to now you were in Hamilton.
It's tomorrow and Sunday.
Which doctor?
Jaffa. Here as possible. Where are you from originally?
I'm here. Originally parents came from Africa. My compala and we left in 67. Well, yeah, but my kids have been. My one son is a gastro.
Okay, in Toronto?
He was in.
Wait, hold on a second. Mayor Ali. No, Abbas, I know Abbas. I know you very well.
So nice meeting you.
My son.
Okay. All right. It'll be good to know that I met you here.
Yeah, both of them.
So Zainab, Abbas's wife, is my wife, Sabira. They grew up together in Birmingham. Oh, let me call her 1 second.
So very confused.
Nadal,
Especially during the World Cup. Bachu or Ali Dina? Ali Dina, yes.
He's my relative.
Really? So you're very well connected to the Sheikh.
That was the wars with FIFA.
Which was the World Cup?
FIFA.
The FIFA, yes.
See, Al Jazeera and Australia, what they
Yes.
All plan, all plan.
We'll join you, inshallah, and we will talk. Nice meeting you.
Nice meeting you too. Oh, I'm okay. I'm okay. I don't.
My name is Murtaza. I'm from Toronto.
Very nice to meet you. Oh, yes.
I could relate to what you're saying.
Yeah, very well. Very nice.
You've been in England for a while.
Oh, yes.
What's your name?
Alexander.
Alexander. So you eloquently describe exactly what I went through with my mom. Precisely. This was many years ago where you didn't have any of these initiatives going on. It was very difficult for me to make a decision when we had intubated her, when the doctor intubated my pocket for us. And we went through a situation where she wasn't improving. And yet she was suffering with an intubation.
Yes.
The kidneys were failing.
Yes.
We had to allow. So when we asked Malana Rizvi, the rest of the money, he said, once you've done that life-saving protocol, you can't take it away. Assalamu alaikum. Okay. Oh, Murtaza. How are you? All right. I met Abbas just recently. So Dr. Akbar and my wife grew up together in Bami. Actually, Nazni is here.
Oh, is she there?
Right there.
Oh, she's sitting next to.
Small world.
Small world.
Nazni grew up in Birmingham. They only from Uganda.
Okay.
India made through them out. They all went to the UK.
Yes.
Oh, okay. My turn now.
Your turn. I'm going to take over. You're going to take over.
You're no longer allowed on the microphone.
What I'll do, what I thought we'd do is we'll announce the Q&A, and then when people are coming with their question, I'll say just to open the discussion, I'm going to have the mic to Dr.
No,
Akmal.
no, you're gonna stay down.
No.
Excellent. What's tomorrow's program? What time does it start?
So it starts. So tomorrow's aimed at the clinicians and the scholars. You're going to be there. You're in
Healthcare.
sorry.
Healthcare.
You're in healthcare yourself. Wonderful.
I'm
So-
in healthcare as well as funerals and end of.
Oh, so you do full service.
Yeah, I'm service after this.
You're the after. You're
I'm
the after
service in this. As I said, I'm a Malikul Mos assistant. He comes in town, does the job, and runs away and leaves everything for us to clear up after them.
If you've had your dessert, can we ask you to sit down, please, so we can start the session? And
I think we start.
please take your dessert and sit down, please, so we can start the session.
Start at 9. I think so. I don't think anybody wants to start earlier than that. No, I don't think anyone can start earlier than that.
What time are we going?
9 o'clock we're starting.
I think there's breakfast.
Oh, I really hope so. Sure.
I think he wanted coffee.
I don't care about food. I just care about coffee. Okay, so why don't if you take your seat and get Sabra, Doctor.
Give Khoja's food and they
It's
forget about everything.
complete anarchy. Oh, I'll get some when the Q&A starts. Inshallah. Let everyone else get some.
You coming
No.
tomorrow?
I'll get some later.
9 o'clock. 9 o'clock.
9 o'clock? I have to come here at 9 o'clock in the morning?
To be fair, I'm organising. That was also my reaction. Like, why did I plan it this way? No, I'll get some later. No sugar, thank you.
Canada's game tomorrow is at 10.
10. What we can? Oh, thank you. We'll have to put the game on the screen. Yeah. So I don't think we've been introduced. Dr. Kara.
My niece.
Oh, I see.
Palliative care physician.
Brilliant and runs in the family, I see. Like, very nice to meet you. Yeah, from your. There we go. So would you agree with that assessment? Is the brilliance definitely in the women of the family?
100%.
100%. Yeah. He's so good at thinking on his feet.
100%.
MashaAllah. So you're a palliative care physician. Well, thank you so much for coming and being a part of this. Also, no, I mean we had a really good conversation in Toronto, so I'm looking forward to continuing that. I think.
I don't know who. I don't know. I sent her the link as well. I approved everybody who registered from here. I don't know who's coming. I honestly don't know the list. No, I think it's Inshallah. Inshallah. Yeah. Yeah. Okay, if we can get you to sit down with your rice pudding. Here.
Salawat ala Muhammad wa ali Muhammad. Okay, so now we're running a little bit behind schedule, so we want to cram in as much as possible. So now we're going to move to the open forum part of the evening. So the way this will work is we have two microphones up here, and there are two floating mics, one for the gents side, one for the ladies side. We will alternate. So if you have your questions, please think them up. We will try to fit everyone in. What I will say is that we're very interested in hearing about your experiences, about your thoughts, your reflections. We may not be able to comment on specific ongoing cases, but I think it's this is an opportunity for us to learn from you. So please, feel free to express yourselves. I think we can all agree that there's no such thing. The only bad question is the question that you don't ask, and we're really looking forward to hearing everyone's thoughts on this. So I just want to sort of give a quick rundown of everyone we've got at the front. There's myself, there's Dr. Matani, Dr. Maulana Zaidi, Dr. Iqbal, Dr. Sabra, and Sister Sabiha, each who bring their own wealth of expertise and experience. So if we could kick off, if we have two floating mics, so if you would like to ask your question, please raise your hand and we'll get one of them to you. And just while you're formulating your questions, I'm just going to hand over to Dr. Iqbal to deliver some opening remarks to kick us off. Please recite a salawat ala Muhammad wa ali Muhammad.
Allahumma salli ala Muhammad wa ali Muhammad. So the concept of the open forum is you can really say anything that's relative or related to the topic that is a burning question or a concept or a point or a scenario or something, and we're happy to engage with that. But one of the points that was made by a few of the speakers earlier, which I want to just reiterate on, is that the most important conversation that you can have around this stuff is the conversation that you have when you are of sound mind and of healthy body. Because at that point you will make the most reasonable and rational sort of judgments. And nobody's telling you to understand absolutely everything. And nobody expects that you will understand absolutely every scenario that you might find yourself in or that your loved ones might find themselves in. But As that one hadith of the Prophet goes, that the sadaqah given while you're alive is better than the sadaqah given after you're dead. The advice or information given while you're healthy is much better than the advice that you're given or you're giving while you're distressed. And so the most important thing that we would like you to take away from today is engage the discussion, okay? Have the discussion. If you have questions around what is on offer for you, we can help you understand that. There are lots of resources to help you understand that, but it's important that you have a sense of what you would like to happen, and where the Sharia has permissibility and such for you. And with that, whoever's first.
So can you just raise your hand if you've got a question? Okay, so we have Uncle at the back.
Assalamu alaikum. So my question is, as devoted Muslims, followers of Ahlul Bayt, we die and we expect to be treated based on our value systems, Islamic value system, according to the teachings of the Prophet and Islam or Ahlul Bayt. And we hope that you reach a system where there is definite answers based on the ulama's teachings, like contribution. In these cases, followers of Ahlul Bayt maybe will come to different maraja, as we do with Masail, maybe according to Sayyid Sistani. In this case, you as followers of Sayyid Sistani, you have to do this choice if you want the satisfaction of Allah subhanahu azza wa jal and to die as a good Muslim. Like, I know this is evolving process and a new field for you, so but the involvement of our ulama with the doctors would be really great, and also would be really nice at the end of the day, in addition to the standard answers, that conclusions that you to have, like consulting, like group, every community having, the Shia community of BC having a consultant group where in difficult situation they could be the parents and the children of the deceased or the brothers and families can turn to and ask for their answer in their cases. Thank you.
I think you very nicely summarized what the goal or the promised land of this whole work is.
I think Sister Sabiha, maybe you can speak to this from your experience working with your community.
Assalamu alaikum. First, I wanted to commend you all for being here. This is a sometimes difficult, uncomfortable conversation. I know that there are competing other events happening, like football matches, where you all could be, so it is really commendable that you're here. And I think your presence here is really testimony that these are conversations that each of us really has in us. We either know of someone who's gone through a situation or are considering it for ourselves. And so having these conversations now, when you are able to objectively think about it, will bear the fruit at a time when it is crisis and you're not really able to think objectively. So thank you for being here. As Dr. Iqbal said, this is, I think, the purpose of the effort, to be able to reach to that point where, as when Dr. Khalili was explaining the scenario of the ICU corridor, and you have these families that are in distress. And distress is a really normal part of that experience, because when you love someone and they are unwell or seriously ill, you are grieving, because there is a part of you that understands that this could lead to death. So there are some very normal feelings, emotions that you will be experiencing that no one can take away from you. That's just being human. Grieving is part of being human. But I think what we're trying to say is that on top of that, if you are struggling with issues such as ambiguity about faith, that should not be what increases your suffering. Faith is a protective factor in all stages of life. When you have faith, it's a buffer. So when you're going through difficulties, faith will be a factor that actually provides comfort. In healthcare as well, faith has been in research documented to be a protective factor. People who have faith actually do better with serious illness, with dealing with the burden of an illness. But time and time again, in my work as a hospice social worker, I have seen that Muslim families who have very strong faith are actually struggling a lot because of the faith. And it's kind of a situation that makes you wonder why. And I think if you dig deep enough, you realize that it's the confusion behind what your faith is trying to tell you. It's the ambiguity, as you said, of hearing different versions of what you should and should not do. And I think if we all come from the starting point that Islam has the solution, then I think we can forge our path ahead to get clarity, get light, and understand what the answers are. And it's a matter of bridging the gap. So the hope is that this effort and continued effort will do exactly that, because Islam does have the solution. We just have to figure out how to connect it with the technologies today and the complexities of medicine today.
Thank you very much. I think Dr. Maulana Zaidi.
Yeah, thank you so much, sister. I just wanted to add something. So first of all, when you are asking about practicing Islamic laws according to the will of God, pleasure of God, and then we must be satisfied that everything has been done according to Islamic laws. So first of all, I just want to mention, and we will discuss more, Sheikh Khalil, you can note down. First of all, we must have Muslim spiritual care practitioners there who are also ulama, and they have understanding of how to provide spiritual care. So unfortunately, I'm just telling you, not only in Sunni Shia, I'm talking about all entire Muslim community, they are not coming to the hospital when you are calling them. It is very difficult to get hold of them, very difficult. And the reason is, as compared to the Christians, because we don't have in our job description, if I am providing services to Az-Zahraa Islamic Center, this is not my job description to go to see the patients in the hospital. And this is why I think we should really discuss this one, and then why we don't have this one. And the second thing is about the difference of opinion. If I'm personally somewhere, followers of Ahl Bayt, Shia patients are also there, Sunnis are also there. So I'm always helping, and I'm looking into the fatwa and seeing that how we can find out the solution. As sister also mentioned, that there is a confusion and they are struggling a lot because of their faith. But they are struggling a lot, but someone must be there to address their struggle or their suffering or whatever they are going through. And unfortunately, in the hospital at that time, I'm not able to go everywhere. So many things are there, and then it's not going to be addressed. So I would say that, for example, from Maraje perspective, there are so many aspects where we have the solution, very solid solution. One must be there, and then you have to go very deeper level. And fortunately, we are going to discuss in more detail tomorrow and day after tomorrow all these kind of issues. For example, one issue I would say the withdrawal. Once you are connected to the life support, for example, according to the fatwa of Ayatollah Sistani, that you cannot disconnect this one. And for example, and then we have to see whether Ayatollah Sistani, is this the fatwa or ihtiyat wajib or something like that? Because sometimes we are, our ulama are ignoring the aspect of ihtiyat wajib, and they're just saying that according to our Islamic law, this is not allowed. So from my perspective, this is not right thing. So if he's saying a'lam fal a'lam, So then we have to see that if someone else, like Ayatollah Makarim Shirazi and others, they have different understanding, they have different fatwa. And when you are in the hospital, you are experiencing a lot of suffering. And you are there to take decision for them. And then you cannot stuck in sometimes that, okay, the taqleed or other things. So you have to find out the solution, and it should also be according to the Islamic laws, and our Maraji are also accepting. So this is just I wanted to share. Yeah.
Thank you very much, Dr. Zay. That's, I think, a couple of key points. One is sort of a structural issue, which is having the right professionals available to support families and patients in this time, and actually to support doctors as well who are faced with these decisions. I think the other one is quite interesting, the question of sort of like, there are differences of opinion amongst Maraj on these issues. I think in some cases as well, it's also that the wording of fatwa, there are nuances there that aren't immediately apparent. And I think there's also secondary considerations, like, there's a whole field called qawa'id fiqhiyya where you have things like, the qaid of la mashaqqa, like not allowing someone to go through extreme distress that may come into play. And I think what we need is what we're working towards is a framework for decision making. Because I think it's also important to note that it's not possible to map out in advance every single medical scenario that a doctor or a patient or a family will encounter. And actually, there will always be, something that comes. Each situation's unique, and it's not always possible to have the marja, whoever your marja is, on speed dial to get the answer. So I think there's also an element where we need to educate and empower doctors, patients, and families to feel confident in the decision they're making. Because I think Sister Sabia put it very nicely, when you're in that situation, the last thing that you should be doing is agonizing over you should feel comfortable making that decision and not second guessing yourself. You should be, if anything, you should be focusing on your loved one who is passing away, not on the decisions around that. That should be the easy part. Sorry, Dr. Mizan, did you want to say anything?
Yeah, I mean, the issue you bring up is an interesting issue, because more often than not, you're not going to be facing a group of healthcare professionals who are Muslim. So they're not going to understand your faith. I mean, whether you like it or not. They're not going to be looking for Ayatollah Sistani's fatwa on what they are going to, on what decision they want you to make. And you're going to be pressurized in making a decision. Trust me, you're going to be pressurized. And there is a time limit for healthcare professionals. Right? I only have, a certain number of ICU beds. And I have an 89, 95-year-old in an ICU bed that I think is futile, but then I have a motor vehicle accident in the emergency room where 2 young people actually need an ICU bed. And so your pressurization is going to be very real. They'll pressurize you to make decisions. So I totally agree with you. I just want to make one other point. What Maulana Sahib said, what Sister Sabir said, and others, is just as there are differing opinions of scholars, there are differing opinions of physicians as far as treatment is concerned. I want to just be very clear with this, because there are some physicians, who may say that no, they should not be intervening, and some physicians may not agree. So it's not as easy as you may think. But it goes back to what Dr. Iqbal said, is the more conversations you've had in advance with your families, the better it's going to be for you. Trust me, you need to be clear with advance directives.
Thank you. Next question. Do we have any questions on the ladies' side? Or any comments, please?
Assalamu alaikum. Thank you, first of all, to Az-Zahraa and the associated organizations for putting this together. I think it's a very important program, and so I'm very grateful for that. So my professional background is a notary, so I'm on the legal aspect of this. I've been practicing for a few years, but advance directives and representation agreements are the items or the advanced planning that I actually don't enjoy, and I'm very hesitant to create. And that's in part because of Why? Oh God. I thought there was someone behind me. Why? So exactly because of this, because it's so contentious and there's so many differing opinions, and I find it very overwhelming to have this kind of pressure of giving Islamic perspective or advice when, first of all, I'm not a scholar, and second of all, the scholars I do reach out to are also very hesitant to kind of like take that on. But this seems very promising because now we're in a place where we are doing the research and we are collecting that information to present it to the community, which is very helpful. There's just a few things that like I wanted to point out. One of them is the reason we do incapacity planning is because you can't have a religious scholar at your bedside. That's the idea, right? So having this idea that you want to be able to call someone up and be like, come, I need you to make this decision is not practical. In BC, we have obviously a healthcare crisis. Every other, we've been hearing as of late, some hospitals shut down completely. And so patients are rushed over to a different hospital. So this idea of that there's like an abundance of, medical equipment and beds available is actually not practical. The other thing that was mentioned that's very important is capacity. So sometimes when we are looking to make that representation agreement or that advance directive, whatever it may be at this point, maybe even a power of attorney, that person, the adult, doesn't have the capacity to give those directives. And so you're stuck in a situation where now you're having to scramble and think about, okay, what's the alternative? So when we talk about making your decisions clear, the province of British Columbia is very progressive. They actually have templates on the government website where you can download representation agreements. And this is a liability on my end, so I'm not telling everyone to go and download and fill it out because you do need a legal professional to walk you through it. And you do need, we have many medical professionals, alhamdulillah, in the community who can also be at your side to say, you know what, maybe just refrain from doing that. So in wills, for example, a lot of people say, I want my will to abide by the Jafari school of thought. And this is quite problematic. Because if a judge sees this, if, for example, your will is contested and a judge sees this, they're not going to abide by the Islamic jurisprudence because they don't need to. Same thing with a doctor. The doctor is not going to come and say, like Dr. Mitani said, they're not going to come and say, what has Dr. Said Sistani deliberated on this? So there's just so many different aspects, but there are resources. It's just how to tap into that and who are our points of contact. So that's, I guess, what I want to say is I'm really excited for this publishing, inshallah, and I'm looking forward to seeing what that comes to. My question, and I don't know if I've said too much and I have the authority to ask. Okay. My question is, where does Islamic jurisprudence, or if you have had the opportunity to speak with our scholars, stand on medical assistance in dying? And specifically, if many of you might know that there was a ruling that was pushed to 2027 to allow for folks with mental health conditions to opt for medical assistance in dying. And of course, we understand that how can someone who might be incapacitated make that decision for themselves? And I'm wondering what your thoughts, if any, on that.
So the short version is that any form of assisted suicide is haram across the board. Multiple scholars, same opinion. With respect to mental illness, I think that becomes even more difficult. And I think that even Western ethics is dealing with that, and which is why it got kicked down further. And so it's interesting, like, and maybe Sheikh Alex can comment on this a little bit, but personhood and autonomy is recognized in Islamic law, but not to the extent that it is recognized in Western law or in Western ethics. And personhood and autonomy is within a framework of your responsibility to God and to your soul, and not just to whatever you want. And so, when we talk about the struggles of people's decisions and the exercise of their autonomy, it is with a view towards guardianship of this body, this time that you spend here, and that this time and this body has to be treated with the care and respect offered to it by God, and hence it is a responsibility to God, and that any premature cessation of that is not allowed.
I just wanted to add that whatever Dr. Iqbal said, doctor assistance is dying is very difficult. Nobody's allowing this one. But there are some other ways that as a spiritual care practitioner, I'm experiencing and going through that. For example, so we have active intervention, we have passive intervention. We are also, but we are going to discuss tomorrow and day after tomorrow, hopefully, that discontinuation of treatment. So whether we can do this one, at what stage we can discontinue treatment, and still, so these kind of aspects are there, but not the active intervention. Yeah.
I just wanted to add one more thing, and that is that we shouldn't, just because we're saying that MAID isn't allowed, doesn't mean that it's not something that we need to think about in our community, because people suffer, and when people are at their nth degree of suffering, people ask about it. And I've had Muslim patients ask about it. I've even seen Muslim patients undergo it. So I think we're doing ourselves a disservice if we don't recognize it, we don't talk about it, and we don't, we have to really understand that people suffer. And when they suffer, they question everything, right? And something that they may not have considered before might come to the forefront. So I think it just really speaks to how we need to support people and support the community through this suffering. So having chaplains, spiritual care support workers, social workers who are faith-based, who understand kind of the lens that we're coming from is just so important.
Thank you very much for responding for that question. I'll just weigh in with a few things. So, in terms of what Maraja have said on this, the unanimous sort of position is that that medical assistance in dying is not permitted, whether to receive it or to administer it. Sayyid Khamenei has a very detailed ruling on this, actually, where he distinguishes between three different scenarios. So he's asked this question. He says there is three kinds. He sort of distinguishes between what he calls three kinds of euthanasia. So there is active euthanasia, indirect euthanasia, and passive euthanasia. Active euthanasia is when the doctor administers treatment to hasten death. Indirect euthanasia is when the doctor provides the patient with the necessary, shall we say, drugs or substances to hasten death. Passive euthanasia is withdrawing care and allowing natural death. He categorically prohibits the first two, and he allows the third under conditions of futility and so on. The position of Sayyid Sistani is that you're not allowed to withdraw treatment. That would be except under extreme circumstances, which are the qawaid fiqhiyya I mentioned. Other marajas such as Ayatollah Makaram, I believe, but Sayyid Shubairi Zanjani and others allow the withdrawal of treatment, but they qualify it heavily that this is only in cases of extreme distress, mashaqqa, and even then it's passive, it's allowing natural death. That's the fiqhi position. I would just like to bring in one other perspective on MAID that I don't think we've touched on, which is that that there is this view of autonomy and personhood in Western thought, which sees the person as sort of an atomic individual detached from other factors, and that has both. And that has a negative characteristic, because I think in a lot of cases with MAID, we have to examine what pressures are being placed on the person in that decision making. There are well-documented cases where a person's relatives are actually pressuring them to undergo MAID because they no longer wish to take care of them. And so this is actually a situation which is a very sad situation, where you have a person who is vulnerable, who is being effectively, indirectly told to kill themselves because they are a burden to their family. I think our critique of MAID has to go beyond the parochial moral position that we're Muslims and we don't do that. I think, as with all of our criticisms of the society in which we live, these do not have to come from a place of, well, this is our faith. I think it has to come from a place of, we are citizens in society and we have a view on this, and I think we need to broaden and deepen our criticisms to include the social and economic aspects of this. So you have the social aspect where you have people being pressured by relatives who no longer wish to care for them. We have the economic aspects of a government that no longer wishes to fund its citizens' healthcare, citizens who have paid into that government's tax funds for, in many cases, decades. And that is not acceptable. It is not acceptable for the government to, of any country, to pressure its citizens into accepting an early death, not to accept it, to actually initiate an early death to save money. And that's something that we need to be examining. And that is a discussion that I think is being completely missed, not just by the Muslim community, but by other religious communities. And that is where I think we as people of faith need to be also directing our criticism. Because this isn't just about, our religion says no. No, this is wrong on, our religion says no because this is wrong on multiple levels. So I just want to foreground that, because actually having done some research, reading these cases, I found it deeply distressing, the thought of people who are effectively alone being left in a situation where they feel they have no choice. And then you mentioned mentally ill people as well. There was a case in Europe, I think it was in the Netherlands, where there was someone suffering from depression whose doctor actually signed off on this, and you're thinking, this isn't treatment. This is actually enabling mental unwellness. So I think that's a really important question. I will say that the research at present is mainly focusing on end-of-life care in scenarios outside of MAID, but I definitely think this is something that we have to address. And as my colleagues have said, this is something that we can't avoid addressing, because, I think, Dr. Matar, you told me just now that you've seen 3 cases recently. This is something that is definitely affecting our communities, and I think we have to look at why that is and how we can address that crisis. And as a legal professional, though, we'd also love to engage you with our research more, so please do get in touch with us, share your contact details, and if you're able to come to the symposium tomorrow as someone who's actively involved in these discussions, we'd be happy to have you there and benefit from your insights. So thank you. If we're okay to move on to the next question, gent side, observing strict justice here. So do we want to move to the gent side? Any questions? Jen, okay.
So under what conditions this do not resuscitate order is permissible in Islam?
Broadly. So let's give you a simple example. The order to preserve life is paramount until the intervention itself is worse than the preservation of life. Okay? So if you're 25, do not resuscitate, not allowed. Right? There's lots of life left. Unless you have some sort of incurable illness where something. I forgot she deals with 25-year-olds that die all the time. I don't. But if you're 95, then the resuscitation itself can be worse than what's on the opposite side of it. And so that's permissible. So the broadness of the permissibility of that rule is context-based. If the treatment, and we consider resuscitation a treatment, we consider resuscitation like a medicine or anything else, or surgery or whatever, it's a treatment. It's something that we offer. If it is worse than the what is residual after that, then you do not need to do it.
But even a young person can get a heart attack or contact cancer, something like that.
So that's, I think, what he was getting at, is that this is not an age-based discussion. It has actually nothing to do with age. It has all to do with what the person's underlying medical conditions issues are. If you have a condition that is life-limiting, that there's no cure for, that, is going to limit your life, then doing a DNR is actually completely permissible. So age doesn't really play into it. It's really what's that underlying issue. Does that kind of clarify things?
Is that in sync with Canadian law as well as Islamic law?
Absolutely, 100%.
Okay, thank you.
And more importantly, Canadian law is actually permitting doctors to initiate the order to do not resuscitate without your consent. So, as I said, resuscitation is a treatment, just like chemotherapy is a treatment. I can choose not to give you chemotherapy. I can also choose to not give you resuscitation. And Canadian law is permitting me to do that.
Okay, got it.
I think that is a really important point for people to understand. That ultimately the decision actually lies with the physician. It does not lie with you. Now, I don't know about Ontario, but I'm sure it's the same. But 99 times out of 100, a physician will obviously seek consultation, have a conversation with the family, the patient, if the patient's got capacity, and so on and so forth, and make the appropriate decision. But at the end of the day, if you look at it purely from the legal perspective, I have the legal authority to decide on whether I'm going to give you a treatment like CPR, DNR, DNR, the contentions actually come ICU.
That's right.
It's the ICU physician actually decides whether you're going to go to ICU. You don't decide. You may think you want to go to ICU. The ICU physician may say, I'm not taking you because I think the intervention, not only, Dr. Sabira, not only, I just want to clarify one thing, not only that it may be harmful, they're not intervening, but the question of whether it's going to be futile is what really is the discussion. So I just want to be very clear about this. I just wanted to make one comment, Iqbal, if I can.
Mm-hmm.
I'm a little concerned with what you said. I really, I think we really did miss out in our research. We did miss out the legal profession, perhaps, in engaging them, because I was a little concerned that you were hesitant in making living wills. I wish it was the opposite, that you were more encouraging in making living wills, because it provides incredible clarity for us as healthcare professionals. So if there is anything that we can do in this research journey process that we're trying to do to make sure that the legal profession is comfortable when it comes to advanced care planning and representation agreements and so on and so forth, I think we should try and facilitate that the best that we can, because it's the last thing I want is for you to say, I'm not comfortable in doing this, because that would really be problematic for me. So yeah, I just want to make that.
Yeah, I think just to echo that, that's one of the reasons. I mean, one of our key aims in the way we do our research is to engage subject matter experts with classically trained scholars. And I think, one of the great things about having these forums is we keep realizing there are more and more subject matter experts we need to involve. So initially we started with the doctors, and then we sort of moved to the psychosocial aspects of care, and we've got the social workers, the hospice workers, and now the legal profession. I think we're realizing there are actually many more professions involved in the process of death and dying than perhaps we initially realized. And so our goal is to, I think, as Dr. Mattai is to include all of them. Did you want to come in on DNR?
I just want people to understand what resuscitation is. Okay? So it all sounds like a magical thing, okay? And so I want you to understand some numbers, and I want you to understand them very simply, okay? If you're here, all right? You're in your home, you're in a place like this, not a hospital, all right? And your heart stops for whatever reason. every single minute that you do not receive defibrillation, 9% of people do not survive. Okay? So every minute that you do not receive adequate CPR and defibrillation, if your heart were to stop, 9% of people don't survive. So that means if you get to 10 minutes, almost everybody's dead. Okay? So that's the first thing about resuscitation. Why do we talk about resuscitation in hospitals? Because hospitals are full of people that know how to do CPR and have access to defibrillators and can deliver defibrillation in a timely manner. Okay? In hospitals that train to deliver defibrillation in a timely manner, the average time in a well-run system to first defibrillation can be in excess of 6 minutes. Okay? So for the first 6 minutes, if they find you and you happen to be on a heart monitor and your heart happens to stop and that all the things go right for you and they start CPR, you still take almost 6 minutes to receive defibrillation. So we go back to my rule of 9%. 50% of people are dead still. People think that resuscitation is some dramatic thing that you will come back. You will almost certainly come back worse than you were. I have done a lot of resuscitation in my life. I have done a lot of CPR in my life. It is not dramatic like on TV. Okay? People don't just go, oh, and they wake up. Okay? They often get a tube shoved down their throat. Okay? Their ribs do get broken. Okay? Honestly, one of the things is we say that if you're not breaking ribs during CPR, you're not doing CPR well enough. And if you don't believe me, just look around. I can tell you where the physicians in the crowd are. I haven't met them all, but they're the ones nodding their heads. Resuscitation is ugly business. It's ugly business. Okay? And so I want people to understand that when we are telling you that I'm withholding a treatment from you or I'm withholding a thing from you, I am doing it for your benefit. It is ugly, ugly business. All right? If I think that you have a meaningful chance of survival and recovery to discharge, that's another important term that we didn't discuss. Recovery to discharge. And the optimal discharge location is home. What proportion of people who receive resuscitation are discharged to home? Any guess? 25%. Adequate defibrillation, adequate CPR, discharge to home. 25%. 40% of the ones who survive are discharged to other care place, either another hospital or a long-term care facility. It is ugly business. I want people to understand. So when we say, do you want resuscitation? Understand, please, what that means.
Question what you said basically from one aspect of the question was related to Islamic, what Islamic scholars are saying. So my question is, when a doctor is choosing to resuscitate, so is there always, can we consider that they have a meaningful recovery possibility is there? Because from if I see like fatwa and other things, I don't know if there is any fatwa related to this one. Then even if someone is 97 years old and we are resuscitating, but I am a physician and I know that there is a possibility of maybe discharge, and then it is also haram because possibility of death is there. Please.
So the most important consideration in resuscitation is the reason your heart stopped. Okay? I'm going to repeat that. The most important consideration in resuscitation is the reason your heart stopped. If I think that the reason your heart stopped is imminently reversible, I will resuscitate a 97-year-old. I will resuscitate a 25-year-old, a 97-year-old, I don't care. If I think that it is imminently reversible very quickly, then I will resuscitate whoever I think will benefit. If I am unclear as to the reason your heart stopped, your survival from resuscitation goes way down. Okay? The reason your heart stopped is the most important consideration. I do procedures on people, and sometimes in the context of that procedure, I tickle their heart and their heart stops. I resuscitate those people every single time because I caused something that caused their heart to stop. It's very different from somebody who is in the hospital for a pneumonia, who is 95 years old or 85 years old, or has a lung cancer on top of that pneumonia and is 45 years old, and their heart stops. Their heart stopped for a very different reason to me tickling their heart. Yeah, hold on one second.
I also wanted to just add one thing, Dr. Iqbal, and that is there's a conception that even if you were to say that I want CPR, or I want as Dr. Sabir has a full code, right? In many circumstances, this would only be applicable to a witnessed code, like somebody that you have witnessed that have had their heart stop. An unwitnessed code is almost never resuscitated, exactly for the same reason that Dr. Iqbal mentioned, because you have no idea for how long that person, his heart had stopped. So it's very important to understand some of these terminologies, because you may come out of this and say, hey, I said, I know my dad is in long-term care, and I said I want a full code, and you guys didn't do anything. Well, they won't do anything if it is not witnessed, because that's considered then a natural death.
I wanted to just take an opportunity to add to what Dr. Iqbal was saying about empowering ourselves with actually understanding what these interventions are and what these terms mean. Dr. Sabira, in her presentation, that was the first step, empowering. And the reason I say this is that because we are average people who may not be in medical circles, when we hear something, we're responding with what we know. So they did this amazing study where they asked average people, and it was a large study, simple scenarios. If your heart were to stop beating, if you were to stop breathing, if you couldn't eat, would you want a feeding tube? Would you want a breathing machine? Would you want resuscitation? And overwhelmingly, average people said yes, because it makes sense, it's intuitive, right? And then they asked physicians the exact same question, and overwhelmingly they said no. And I think there is some wisdom here, because the physicians understand the futility of those treatments, not just the futility, but the added burden. And so empowering ourselves with understanding exactly what that procedure or what that intervention means is really critical, because you will be in that situation where these words will be thrown at you. And sometimes the louder voices may overpower your objective thinking. So just something to take from that.
I think there's been a really good discussion based off the DNR question. I'm conscious of time because we are up against the clock for Salah. So we've got about I think two or three minutes left. So I just want to see if there's any more questions from the any more questions from the lady side. Final question. Yes, we've got sister there. We'll have to keep it brief.
I don't know that my question will be brief, but
Well, Tawakkal ala Allah, we'll do our best.
Sorry. I understand that the publication is not ready yet, and looking forward to having that publication as a guideline. But are there some guidelines or highlights that we can use as Muslims to create or talk about for the representation agreements and the enduring power of attorneys? Because I think that it's imperative to have these conversations when like you said, when we're healthy and of sound mind. But it's futile to have the conversation if you don't know what the Islamic law is. You can say I don't want it. You can say I want a DNR, but if you don't have a illness or you don't have reason that you don't qualify for a DNR according to Islamic law, then you can just say it, and then all of a sudden that's your representation agreement and it's incorrect. So I think is there something that, I don't want to rush the publication, but is there something that we can start to have in our hands so that we can start these conversations, because it's so critical?
I just want to make one point before we even talk about publications and guidelines, and that is, I think we're making things more complicated than we need to be. When we went to the ulama, what we actually realized is we actually are very close in what we're thinking, and what we're all thinking is we want the best for people, and actually we don't want people to suffer. And so actually where I think a lot of the public is kind of struggling with is actually not a struggle. And actually what we found was when we were asking the questions of the ulama, they were actually on the same page as us as physicians. So I think if we're going to take anything away from this is that, physicians aren't trying to harm patients, right? We're not trying to harm patients. We're not trying to shorten people's lives. We're actually trying to do the best for the patient at that moment in time with the best information we have. And the ulama actually agree with us in that regard. They would say that if your doctor is recommending or not recommending a treatment, that actually overwhelmingly, apart from a very few certain scenarios, such as like withdrawal of care where there's some ambiguity, that actually they were in favor of following the physicians, the healthcare professionals' recommendations. So I think that's really what I want to take away as a take-home message, is actually show trust in your medical professionals, because actually they want the best for you, and actually the ulama want the best for you, and actually we're very, very close in that sort of recommendation.
I know we're really short on time, but I was just going to add one more thing. The default in this is not that you would get a DNR. The default goes back to legislation. And legislation says, like Dr. Muftan was saying, practitioners have that autonomy to make that decision. Correct. So even if you don't have a representation agreement or power of attorney, it's not the worst thing that can happen. Oh, I'm so sorry. It just means that you haven't made that specific decisions for a DNR or that specific decision for MAID. So we're reverting to legislation. Sorry.
So I think we're up against the clock now. It is time for start. I will just say that one thing that's come out of this has been advanced representation and sort of the legal aspect of this. So maybe if you can both connect with us with your specific questions on this, we can look at maybe giving some specifics on that, because I think that's a really important conversation. Just as we close for thought, I want to thank once again Az-Zahraa Centre for hosting this, Nasimco and IMI Canada and the WF for facilitating this and supporting this. I want to thank each of our panelists, Dr. Matani, Dr. Maulana Zaidi, Dr. Iqbal, Dr. Sabra and Sister Sabiha for sharing their expertise. And I want to thank everyone here as well for the questions. And I just want to apologize that we haven't gotten through maybe as many questions as we would hope for, but we want to continue the conversation. So please do connect with us. If you have more questions, we are reachable. And I would just like to end by asking if we can all just recite Dua al-Faraj together. بسم الله الرحمن الرحيم اللهم كن لوليك الحجة بن الحسن صلواتك عليه وعلى آبائه في هذه الساعة وفي كل ساعة وليا وحافظا وقائدا وناصرا ودليلا وعينا حتى تسكنه أرضك توعا وتمتعه فيها طويلا برحمتك يا أرحم الراحمين وصل يا رب على محمد وآله الطاهرين.
We have to keep 20 chairs, guys. Here, let's keep 20 chairs available.
Here?
We can keep it, yeah. I think we can keep it where it was.
So this is your problem now.
We can move these.
Because they move this back then.
Why?
Because you're going to need to move this here. Well, you don't want to.
We don't need this, so we're going to take this through. Just one more thing there.
Oh, okay.
Almost, yeah. Just one more here.
So this table's underneath.
Yes, I'm not ready for push more.
Yep, got it. Good? Yeah. What are your shirts? Double rows down? You sure?
Yeah, or we can do you like this as you wish. It's a you anyway, but whatever it's easier. So, yeah? Do that. Yeah.
Do what they want.
Exactly. I